So we're going to start off today with an upper blepharoplasty, and initially we're going to mark everything up carefully to make sure that exactly the correct amount of skin is removed to correct all the overhangs that we've got. So the marking up is the key critical point at the beginning of the procedure that really makes sure that we're planning the whole thing to perfection. Ideally, you want to be putting the scar in the crease above the eyelid in the supratarsal crease. So there's usually a little fold, looks like it's about there. It's usually about 1 centimetre above the lid margin. It should be about the same on both sides. And then we'll just double check that this crease is in about the right area. So that's exactly 1 centimetre, which is great. Just looking here, we can see that the eyebrow skin is a smidgen low itself, and that's not correctable as part of an upper blepharoplasty procedure. But most of the issue here is the excess upper eyelid skin, or the dermatochalasis, and that's this bit of skin here that's hanging down here, and that is excess skin and also a little bit of excess orbicularis muscle. So the orbicularis muscle is the muscle that sits underneath the eyelid skin. It goes all the way around the eye, and it can be a little bit bulky, particularly at the side here, laterally. And so this orbicularis muscle contributes to the lateral hooding that you get at the side here, and we'll be taking away a bit of that there as well to reduce the weight at the outer part of the upper eyelid in particular. So we'll just draw in the rest of the supratarsal crease, which is where the lower scar goes here. So this is going to be the final scar position. So this is where the scar ends up. So this is the amount of upper eyelid skin that you're going to leave behind, that you're not going to disrupt. And so so the tarsal plate is the fibrous layer within the upper eyelid that maintains the structure of the upper eyelid. So it's important to keep that at all costs, and that doesn't usually get shortened. And this is a slightly different length in different people. Some people have different eyelid shapes, so it's important to treat each patient as an individual and do a slightly different procedure in each case. But people with slightly different eyelid shapes would naturally have more of their eyelid visible with their eyes in neutral gaze in an open position. And some people would have very little of that, and that depends on each individual's anatomy and sort of the prominence of the frontal bone or the supraorbital ridge here. You can just open your eyes again for a sec, please. That's great. So here we can see quite a lot of the eyelid on show. That's a normal variant. In some people, you'll be able to see only 1 or 2 millimeters, or actually in some very young people, you can't see any of the upper eyelid, and that's just differences in normality for different people. So at the outer corner, you have to bring the scar out to past where this bit of hooding sits at the outer corner of the eye. If you don't do that, then you can correct this bit of hooding above the central part of the eye, but you don't correct the bit at the side. So to correct this bit at the side, the scar really needs to come out to about here. And to make the scar as hidden as possible, we will be aiming to fit the scar within one of the natural creases at the corner of the eye there. So this just slots into one of the creases, so that with time it just fades to look like a crease, and you can't really tell that anything's been done. When you're doing these operations, you basically end up cutting out an ellipse of skin here. So the upper scar is always longer than the lower scar. And to address this and make the scar make the lengths of the upper incision and the lower incision more similar, one of the tricks you can do is pointing the scar upwards at the outer corner slightly to make the lower one a little bit longer and more in keeping with the length of the upper scar. Just double checking that when we do take this amount of skin away, that's definitely not going to pull the upper eyelid up and create any difficulty with closure, which it won't. It's always a bit more difficult to tell that once the local anaesthetic's in, so important to check it beforehand. And then I've taken the scar slightly closer to the inner corner here towards the nose, but not across this bit, just to try and correct as much of this skin at the inner corner as possible, whilst avoiding the bow stringing across the corner there. And you can see that once that's closed, it's not going to put any tension on the upper eyelid. It'll just freshen things up nicely for it. And we don't really have, if we did have any fat excess here, I'd be marking it out to have a look at it. That's usually where you get the fat excess, if there is any. And sometimes I'm just going to gently press on your eyes here, okay? Sometimes by gently pressing on the eye, you can just see where there's a bit of a bulge, and if there is a bit of a fat that's a bit sensitive to bulging through at these corners, you can tell that you get an extra bulge on a slight gentle pressure onto the eye here, and we don't really have that here, which is good because it means that we don't have to correct that as part of the procedure. Excellent, that's great. You're all ready to go. Are you excited?
Yes.
Yeah, fantastic. So we're just putting the local anaesthetic in as slowly as possible, just really, really gently creeping forward to put the fluid in directly under the scars. You don't need to put the fluid anywhere else, as once the scars are numbed, that's really the whole area nice and numb. Slowly advancing it along the lower incision and then the upper incision to make sure the whole of both scars are nice and numb. When you're putting the needle in for a second time, you're aiming to put it in through an area of the skin that you've already numbed with the previous injection so that it doesn't scratch quite as much. So here we are, all nicely prepared for the start of the procedure. Everything's been clearly marked, the whole patient's face being nice and sterilised. We've got all the drapes in place, and we're going to be removing this area of skin here, so quite a large area of skin here. We'll be planning to take away the superior 2/3 of the orbicularis within this area, so we'll preserve some of the muscle lower down here, and particularly at the inner corner, but we'll be removing the superior 2/3 at the outer part of this incision of the orbicularis muscle to reduce the bulk and of the weight that you get at this part of the overhang here, this part of the hooding that you get at the side. So we'll start with the lower incision here, the inner corner. Coming all the way along. Down to this point at the outer corner, which then fits up into one of the natural creases at the corner of the eye with this upward sweep here. Move on to the upper incision, again starting at the inner corner. That's great. We're then going to peel off the excess skin, starting at the outer corner, coming all the way along, so preserving the muscle initially. Just coming on the underside of the skin, so you can see the muscle being left behind underneath. This is the orbicularis muscle that we're going to be removing the upper part of shortly. And we'll just take away the skin on top of that. So it's a very clear plane here between the pink muscle underneath and the white skin on top. So you can just see here that we've removed the whole of the skin in the upper part of the eyelid, and this is the orbicularis muscle that we were talking about earlier underneath. Now in some people this would be the end of the resection and we would just be closing up, but in this case we've already identified a little bit of muscle excess at the outer portion in particular. So this is the excess bulk that we were talking about that you could see beforehand. So this is the muscle that we're going to be removing slightly. So we'll leave the lower portion, so we'll be preserving this bit of the muscle down here just above the eyelid, but we'll be removing the bit that would leave us with a bit of excess bulk at the outer portion up here, and that'll just debulk this area of the eyelid, improve the overall aesthetic result afterwards, and give a lighter, fresher, brighter look that's a bit more open with less weight at this portion. Here we're just cauterizing the tiny little blood vessels to make everything a bit clearer to see, stopping these little blood vessels from oozing. They would stop on their own, but if we stop them with some of the diathermy here, the cautery, it just reduces some of the bruising that patients get as well. So they get a little less swelling and bruising after their surgery. Because that's one of the downsides of this procedure that everybody worries about, getting a bit of bruising and swelling that takes a bit of time to recover. So people could be quite self-conscious about that in the immediate post-operative period for about a week or so afterwards. So anything that we can do to limit that is obviously greatly appreciated by all patients. So previously, when these upper eyelid operations involved more invasive surgery, removing more of the fat compartments that sit deeper within this area, you tended to get more swelling after the operation. Patients now recover a lot quicker because we preserve that, so they get less swelling after surgery, and this means that people can usually get back up to going back to work within about a day or two after their stitches are removed. And we normally remove the stitches about 5 to 7 days after their surgery, so usually after about a week, with a bit of makeup on to cover up what's left of the bruising and the swelling. You can get back to fairly normal activities without feeling self-conscious. So here we are, having cauterized the orbicularis muscle here to keep everything nice and dry and minimize the amount of bleeding and bruising that we get. And we're going to be removing the superior 2/3 of this muscle, particularly at the upper outer part, less so at the inner part of the upper eyelid here. So this is the bit that we're going to be removing, and this bit under here we're going to be preserving. So this here is the roof fat, which is the fat that sits underneath the eyebrow in the area above the upper eyelid. So this is totally different to the orbital fat, which was traditionally removed, which is deeper but lower down within the orbit. This roof fat can also be debulked as part of an upper eyelid surgery. It is something that I would do in somebody who has a particularly bulky upper eyebrow area, and you can just do that through this scar at the same time. That doesn't need to be done here. So whilst all these seem like small little details, they're all just essential parts of the procedure that are required to make sure that we get as perfect result as possible, and make sure that the scar settles as quickly as possible, so that patients can get back to their normal selves with as short a recovery time as is achievable. So if we were going to remove a little bit of fat from the inner corner of the eye, the medial orbital fat pad is the most common area to get a bit of a bulge here at the inner corner, and that's right down here. It's a bit deeper. We don't need to go fishing for that today because we've already decided that there isn't a significant bulge. We don't have any of the fat herniating through in this particular case. There are lots of different ways to close this upper blepharoplasty. The way that we're going to do it today is with one stitch all the way along that starts at the inner corner here and finishes over here. And then there's just a bit of tape on the nose, a bit of tape here that holds the stitch in place for a few days until it's removed later in the clinic. Whilst you can use interrupted stitches to position the scar all the way along, patients find it more comfortable to have a single stitch that runs from one end to the other, that's just removed by putting at one end, and the whole thing just slips out in one go. So it's much more comfortable for patients. It does require particularly careful placement of the stitches all the way along, as if you do get the stitches in an imperfect position, you get more scar tethering, and that takes longer to settle. So placing these stitches in the right position to make sure that everything looks nice and smooth at the end of the procedure is pretty key to the whole operation.